So welcome everyone to another fresh episode of Fresh Air. And so we have our normal team and we have another member to our team of Fresh Air. So just wanted to introduce the newest member of the team, Dr. Sharada and Matt, who'll be joining us and will be helping to give her expertise to some challenging cases. And so once again, we're going to have some amazing cases from Dr. Irene, who's going to present some cases on cryobiopsy, which being in Canada in the frozen tundra right now, it feels very fitting. So take it away, Irene.
Interstitial lung tumor. I hope you have put your children in bed because this is stuff for grown-ups. And I'm going to show you some cases. And I plan to read the history, and you decide who wants to talk about the case first. Is that okay?
Sounds great.
Yeah, perfect.
So let's go with the first case. With the first case, it's a 40-year-old man who is a non-smoker, who has no relevant medical history. He takes no drugs. He has no expositions. And after an upper airway infection, he starts with progressive dyspnea. So the CT says OP, and he is treated with corticosteroids with improvement. After 3 months of treatment, they take out the corticosteroids, and he has a relapse. Who wants to talk about the cryobiopsy?
Any volunteers, guys? Otherwise, I can do it.
So I guess, yeah. Go for Raghav.
Go for it,
Yeah.
Raghav.
Yeah, let's do it. Yeah. I see very good pieces of biopsy. Big piece of cartilage, though. It takes up most of the space in the cryobiopsy. So obviously that area is you can't interpret. But otherwise, I can see good amounts of alveolated lung parenchyma, but most of the stuff looks like tumor, neoplastic lesion.
No, wait, Raghav, this is ILD, so you can't make any other diagnosis except
I don't know.
And the CT said OP, so you have to correlate with the CT and make it OP. Remember
I should make it OP, but I don't see any fibromyxar flux of organizing pneumonia, even though the CT says OP. Does the CT said OP, that means it's ground glass opacities or consolidation? That's what it means?
Consolidation. I think they said consolidation, but the diagnosis was OP. I think these easiest cases are for the braids that stand. So this is a very easy case for pathologists, but the patient hasn't been diagnosed for months.
Means I don't see any features of OP here. Obviously, I'm disagreeing with the radiologist. I don't know how far that's going to go well. But at this point of time, all I see is papillary structures, the tumor cells exhibiting.
Is this the interstitium, or maybe it could be some? Yeah, I think it is the interstitium. Well, I don't know. Maybe some fibroblasts here, but we are not sure if.
Exactly. I feel that there's some fibroblastic proliferation in between those tumor cells. Again, if it is interstitium which is expanded, usually I try to look for any lining alveolar pneumocytes or something like that. Here I'm having difficulty differentiating. Obviously, everything looks tumor cells to me because there's too many tumor cells lining and everything. But they're clearly forming papillary structures. So I'm inclined towards thinking that it's a adenocarcinoma, whatever I'm seeing. But can it be?
This is what it is. I think in this era of non-doing biopsies in ILD, I wanted to show this example because not everything that looks like OP, it's OP. In the CT, I mean, I'm not saying that I don't know. I don't know what you think if they had to, because I know OP is so frequent that maybe you don't have to biopsy every person. But obviously, if something doesn't go as it should, you should.
Yes. In fact, Irene, I think this is a common reason to biopsy OP is because it doesn't resolve. So somebody has an infiltrate and it doesn't resolve. I think the reason that they biopsy most of the time is to exclude something like this. So they're suspecting OP, but they want to make sure it's not malignancy. And most of the time it's not malignancy. But a case like this actually proves that they should be biopsying cases that don't resolve and are on the borderline between a OP type picture and a adenocarcinoma type picture. The other thing I'd like to say is that it even shows how nice pathologists are. Look what Raghav did. Even though this is absolutely clear-cut adenocarcinoma, he still tried to see, could there be some OP there? Is there some way that the radiologist is right? I think we do that a lot as pathologists. Somehow we try to make nice with the radiologist, even when it is clear that it's wrong. It's just pathologists are nice people.
Not nice, but I always think that somebody has thought that for a reason, and I want to be sure that if they are right or not to say it. I mean, to be sure that because it's a doctor that has thought that there was something. So I want to look for
any thoughts, Sharada, Matt? Any thoughts about this case?
I was just thinking like the adjacent lung parenchyma, can it not show OP? I mean, it's not in this case generally. Like I know it's malignancy should not be made when there is acute lung injury changes. But I'm just thinking, since the radiologist is calling it OP, can there be a possibility of OP still?
Yes, of course. I think that the fact that the radiologist made OP doesn't change my mind at all about the pathology of this case.
Yeah, of
so
course,
it could be OP somewhere else. It could be OP in the background of this. In fact, what Irene was showing is the fibroblasts in the back. Maybe there is some OP there. But I feel that the fact that this is adenocarcinoma is the more important thing. Exactly. Yeah, like she's circling it now. That could be some OP in the back, but I think that's irrelevant. I think what's more important is that there is adenocarcinoma here. And we shouldn't underplay that just because there might be OP along with it, or
I agree as well. And maybe the history that I think they got some steroids. Maybe there was a more predominant OP picture in the beginning, and then that part resolved. And now what we're looking at is the thing that got worse was the cancer that obviously didn't respond to the steroids.
Yes, and of course there's also another possibility, Sharada, is that there is no OP. That maybe this is a desmoplastic stroma, and that is just that adenocarcinoma sometimes mimics OP. When it becomes very confluent like this.
Sometimes. Go for it.
I was just going to say, when people call this... Sorry, Irene, go ahead. No, I was just going to ask, would people call this micropapillary or papillary? I know people often don't call that on biopsy, but...
Can we see it higher, Irene? Like a little bit higher, Mag?
To me, I think there's some micropapillary areas.
Yeah,
there.
Me too.
Yeah.
Papillary here because we have vessels.
Correct.
Yes.
Micropapillary here.
Yeah. I think I would describe both.
I think that, here, as you see stroma with vessels and the malignant cells covering it, it's a papilli.
Yes.
And these that are little flowers without stroma are the micropapilli.
Yes. Can I ask you all guys a question? A multiple choice question? I'll start with you, Irene, since you're talking, okay?
Sorry, here yes. You see the opposite. It's a Nassini.
Oh, that's a Racina. Let me ask you the question, Irene. So my question is, in pattern recognition, the micropapillary, papillary, acinar, lipidic, is the reproducibility between pathologists good, bad, or intermediate? Depends on pattern. Irene, what would you say? Good, bad, or intermediate? The reproducibility between pathologists.
I struggle to see the patterns, so my impression is that it's bad.
Bad. Matt, what do you think?
I would say super bad.
Super bad.
Yeah.
Raghav?
I agree with Matt that it's super duper bad.
Super duper. Sharada, what do you think? How is the reproducibility between pathologists for
I
pattern?
feel it's okay, intermediate.
So nobody thinks it's good, right? So nobody thinks that if you show two different pathologists the same case, they will give exactly the same view on every case of adenocarcinoma, right? For pattern recognition.
I think the papillary and the micropapillary, I think we are good. Solid also we are good. But when it becomes acinar and lepidic, I don't know what's lepidic for your taste and what is lepidic for my taste. And also depends on the day also. Mondays, the lepidic is different. Tuesday, it becomes different.
Collapse. I won't argue with a pathologist because of patterns, I think.
Yeah, me neither.
Even I feel the same, that there's a lot of confusion between lepidic and acinar pattern. What one says is lepidic, maybe somebody else says it as acinar. So
correct. And everybody thinks they are right. Yeah. All right. Yes. Great case, Irene. Great case.
Also, just wanted to add one more point about the organizing pneumonia, especially in the needle core biopsies. When they are taking a core biopsy, generally, sometimes they only get the organizing pneumonia part, which is at the periphery, not the tumor. So if the patient has got a big lesion on imaging, we generally try to make it a point that just seeing organizing pneumonia, no tumor, and if you're still suspicious, then probably you have to resample and reassess the situation, something like that.
Raghav, has that happened in practice to you? Like the first biopsy was OP only, and the second biopsy is all tumor?
I have not keeping track of it, like the same case like you mentioned first, but we do have seen some cases like that where we see organizing pneumonia in one fragment, then tumor in another fragment, maybe at the edge of the piece you have some tumor.
Yeah,
but
of the patient same biopsy, correct? Of the
same biopsy, correct. Yeah, and then patient has a big mass sitting there. So we have seen that every now and then. It's not very common. We do think we have some expert people, interventional people, that they always try to get tissue, and we try to save it for molecular testing. Don't do all the stains possible and exhaust the tissue.
Yeah. Could it, so do you also do that with granulomas, Raghav? Let's say you have a necrotizing granuloma in a biopsy. Would you say, well, this is a necrotizing granuloma, but be careful, there might be tumor nearby, or do you don't?
No,
we only for OP.
Only for OP. That's an interesting question, and it looks like a trap, but we'll take it.
Yeah, because what I'm trying to imply here is that I think that implies that you're saying that necrotizing granuloma is a more specific diagnosis that almost implies that there's nothing else going on. That is the main lesion. Whereas OP is not necessarily the main lesion and could be at the periphery of a tumor. That's what you're saying, right?
Yeah, only if all the dots do not match or become a line, then otherwise, like, it could still be OP can explain a mass lesion and everything. Yes, but great point.
Yeah, guys, any thoughts? Other people, Irene, Matt, Sharada?
I just think it's important to correlate with the radiology, right? And so if it's like a solid mass lesion, that's pretty unlikely to be OP, right? And I agree with Raghav. In that scenario, I definitely put a comment. But if it's like bilateral ground glass lesions that the radiology is favoring OP, then I don't put in any comment because it fits.
All right.
So often to see, it's so often to see OP next to things. Not that often to see granulomas next to other things, though I have seen it.
Yes, I have also seen it. I've also seen granuloma next to tumor. Yeah, so I mean, you can always say that, you never trust a benign diagnosis because there can always be a malignant diagnosis next to it. But I think the frequency of that is actually very, very low in real life. That when you get a benign diagnosis, most of the time it is that benign diagnosis is the lesion. It's very uncommon to have that it's missed the tumor and it's something else, but it happens. I'll agree that rarely it does happen sometimes.
Something that made they think this patient had not a neoplasm also was that he was a non-smoker. This talked against tumor. We see more times biopsies of patients that are smokers because they are more suspicious if there is a smoking history that more benign looking lesions could be malignant, but in this case it was not. Obviously we did NGS, obviously it had something, and
yeah.
and so we are talking a lot about tumors in this ILD session.
Irene, one last question was this a cryobiopsy or no?
Yes,
it was. So you guys do cryobiopsy even for tumor? Oh wait, this was suspected ILD, so I understand. Okay, got it.
No, but we do.
For tumors?
Yeah, even we do cryobiopsies for tumors.
Wow, interesting.
And if they are peripheral, the pulmonologist here does radial EPUS.
Okay.
A bit peripheral lesion.
Yeah. We get big pieces by doing cryobiopsies.
Yes, this is an awesome biopsy.
Oh, sorry. I wanted to show you how much. It's like 7.5 millimeters. So this gives you more tissue.
Yes, for sure.
I've seen some people, we get good DNA and RNA from this, and I've seen no artifact of this freezing. And we also culture the cryobiopsies, because I've heard some people saying you cannot culture cryobiopsies or you cannot, but we get positive culture from this, and we get DNA and RNA. So for getting big pieces of tissues, cryobiopsies are awesome.